Good morning, everybody. It's 8 o'clock Pacific time, and so we're gonna get started with the webinar. I know there are people still trickling in, but we have a bunch of announcements that we want to make. So first of all, as you will see shortly, our speakers today are Judith Wong from the Environmental Health Institute in Singapore, and then Elke Wollants from Belgium, the Rega Institute of the KU Leuven, and she will be talking about measles. So before we get started, just a few announcements. We do have a town hall meeting for the RCN on October 18th. If you're interested in joining, I'm pretty sure that this should say 11 a.m. to 12 p.m. Eastern time. It will not be a 13-hour meeting. If you'd like to register, please scan the QR code here, and we'll also send out
Ellie, sorry to interrupt you. It's not changing the screen.
Oh, okay. Can you guys see the RCN student Discord now?
No, I think
no, it's in the presenter view.
Okay, weird.
Oh, now we can see. It's just was
Okay,
now.
I'll just do it like this.
Yes.
So here's the QR code for the town hall meeting. And then we also have a student Discord, which you can join if you'd like to discuss papers and other topics related to wastewater-based epidemiology. And we will be having upcoming student journal club meetings. Ongoing activities include the monthly journal club, webinar nominations, and our email list. Please reach out to us if you want more information about these. And lastly, just a plug for next month's webinar, we're going to have a special Swiss edition with 2 speakers from ETH Zurich talking about some of the work happening in Switzerland. So with that, I will stop presenting, and I'd like to introduce the first speaker, Dr. Judith Wong from Singapore, where it is 11 p.m. So we're very grateful for her joining today. Judith, do you want to?
Sure, let me share my screen. Okay.
Just a
Can
quick
everyone
reminder, everybody, to please put questions in the Q&A as we go, and then we'll be moderating questions at the end of the talk. Thank you.
Okay, so thanks very much, Prof. Ali, and thank you everyone for the chance to share our work and Singapore's experience in wastewater surveillance program for public health. We're really glad to be here. I'm from the National Environment Agency from the Environmental Health Institute, and I also participate as part of PREPARE program from the Ministry of Health. And for that is the flagship program in the Ministry of Health for research for pandemic preparedness. So with that, allow me to start briefly to introduce Singapore's work on wastewater surveillance. So this slide here briefly summarizes our wastewater surveillance network, which we have for Singapore, where unlike most cities, which relies on monitoring wastewater treatment plants, we are really looking at sampling from manholes. And so we use auto samplers deployed at manholes to get a higher resolution of the signals in Singapore. And this is because, unlike most countries, we are very short of land. We are a population of 5 million people living in 720 kilometers square. So we are very dense, and it is important to have the higher resolution to understand what's happening in different neighborhoods and so on. So at the peak of the pandemic, we had a peak testing capacity of about 5,000 tests per week. And this was achieved thanks to partners in the universities and commercial companies, as well as government labs. So the list on the right summarizes the various use cases that we have thus far. And we have developed as Singapore transited from a pandemic situation to endemic monitoring. Of course, we started wastewater monitoring for COVID-19. Before that, we haven't really had a public health surveillance program. But since then, it has expanded to other infectious diseases. And I will share some of these efforts in the next few slides. So allow me first to take through the COVID-19 experience that we have. And this graph here summarizes the waves of infection that we have experienced in Singapore, as well as how Singapore managed the COVID-19 situation over time. In the early days, similar to most countries, we had a circuit breaker And we also implemented various safe management measures. And of course, when we launched our vaccination program and achieved a good vaccination rate, we slowly phased out clinical testing, and henceforth we have eased all COVID-19 measures. So similarly, for wastewater surveillance, our wastewater surveillance program also evolved. So in the early days, we started our program as early as February 2020. And this was even before initial reports of wastewater surveillance for SARS-CoV-2 was out. And we were actually inspired by the 2003 SARS outbreak because we knew that the virus was shed in feces. So we initiated some initial surveillance efforts and R&D. And so this allowed us to quickly deploy the wastewater sampling efforts when the country needed it. We initiated the sampling at high-density living premises and then progressively ramped up across the community. Having seen how it could provide non-intrusive surveillance for monitoring the COVID-19 situation, it allowed us to highlight areas at risk and to prioritize our COVID-19 measures, including testing resources. So as we ramped up and covered the country, we then also were able to monitor subsequent waves of infection. And of course, currently we are monitoring other diseases such as Zika, as well as using it for aircraft wastewater monitoring. So in the early days, we monitored blocks at risk of transmission, as I mentioned earlier, and the positive detections actually guided the deployment of swab testing resources, whereas negative signals averted the need for costly swab tests. So this allowed us to do really active monitoring for cases and allowed them to be treated in a prompt or taken care of in a prompt way, as well as to implement control measures such as quarantine measures in the early days when the virus was really still unknown to many of us and when we needed the stringent control. Of course, as we shifted towards endemicity, we were really monitoring trends rather than doing the case detection at block level. So as we shifted towards endemicity, we were monitoring trends, various ways of transmission. And then, of course, as with many other countries and laboratories, we monitored the variant population. So allow me now to share something which is more recent, which was something that we deployed in an endemic situation. So as we are no longer case tracing and we are really trying to understand trends so that we can project, for example, hospital beds, as well as whether or not we need to collaborate our healthcare resources. The monitoring in December 2023, when we have relaxed most of our COVID measures, we actually experienced the wave due to the JN1 variant. And when we were actually at the peak of the wave, and we were wondering whether or not it would come down, the wastewater data, because there was a declining case ascertainment as we transited towards endemicity, contributed to the modeling analyses of the reproductive number for SARS-CoV-2. And at the peak of the transmission and peak of the wave, we already saw that the RT was coming down. So this suggests that there was no sustained COVID-19 transmission, and it allowed us to calibrate our health policies. So this is an example of how we have used wastewater surveillance in endemicity. And of course, more recently, some of us might be involved in the Global Wastewater Surveillance Consortium. There's also increased interest in aircraft wastewater monitoring. We had similarly done an initial trial in the early days to monitor aircraft wastewater. And in our time-limited study of aircraft wastewater monitoring, we showed that we were able to successfully detect SARS-CoV-2 variants in both mid and long-haul flights. And the detection in airport and aircraft wastewater really allowed us to sort of see and demonstrate the use case for this mode of surveillance. So we detected variants which were found in aircraft and airport wastewater, which preceded the detection in community wastewater or in community reported cases. So this can be seen where the solid shapes actually show the aircraft wastewater signals as well as the inland wastewater signals, whereas the open shapes actually detected the cases reported at the same time. And we can see for most of the variants found in the aircraft wastewater, the detection in aircraft wastewater preceded the cases reported inland. Further, we also tested the wastewater samples from these aircrafts for other viruses beyond SARS-CoV-2, including a range of respiratory and enteric pathogens. And interestingly enough, we were able to see that the various respiratory and enteric viruses were in different proportions based on the region of the origin cities. So collectively, our findings actually demonstrate the feasibility of this mode of surveillance for global monitoring. And it would be very powerful, not relying on just one airport such as Singapore, but if we had a network of different countries coming together to share data, these signals would really help to provide early warning of global pandemic threats or early threats, or early pathogen threats. So moving on, I'll share another use case that we had in terms of extending beyond SARS-CoV-2, and this was for Zika wastewater testing. So in Singapore is actually not endemic for Zika, and we see cases from time to time. However, in 2023, we had a cluster of about 15 cases, which was reported in northeastern Singapore. And because we knew that the virus could be shed in the urine, we then hypothesized that perhaps we could detect Zika signals in wastewater samples. So as such, when the cluster of cases were reported, we deployed autosamplers in the neighborhood in areas of increasing coverage. And we also deployed mosquito traps in the neighborhood to trap the Aedes aegypti mosquitoes or Aedes albopictus mosquitoes, which were known to be vectors of Zika transmission. So having deployed the samplers, both the mosquito and the wastewater samplers at the area, we then actually detected positive signals in the mosquitoes as well as in the wastewater. And the chart on the right actually shows the peak in the number of cases, which also corroborate with the peak in the signals of wastewater samples, as well as the number of positive Zika mosquitoes or Zika positive mosquitoes from samples collected. So collectively, we demonstrate and describe a use case of wastewater and mosquito surveillance to detect Zika. And this was actually very, very important for Zika because we know that unlike other infectious diseases, Zika is actually a very mild disease. However, and so there could be a high rate of asymptomatic shedding. But this is also very concerning because we know that Zika can cause severe outcomes in a subset of the population, such as in pregnant women where they may cause microcephaly as well as other congenital defects of the unborn fetuses. So because of this, we felt that we wanted to enhance the surveillance of Zika. And so we had henceforth now operationalized the surveillance efforts for Zika, where we enhanced Zika monitoring by integrating mosquito and wastewater surveillance to complement the conventional case monitoring. So this combined surveillance efforts help us to monitor for Zika transmissions, especially for even new or sporadic cases, since we do not see it in Singapore very often. So interestingly, in February this year, we also detect persistent signals in another area and another neighborhood in Singapore. And because of that, this actually prompted a public health alert of Zika transmission in the area. So this is a demonstrated use case of how wastewater surveillance beyond SARS-CoV-2 has been used to alert for public health response and guidance. And of course, with the alert, we have also stepped up mosquito control measures in the neighborhood and also issued advisory to the population. So with that, I would like to also summarize some of the local efforts in terms of the capacity that we've built over the years since COVID-19, where we have also deployed and relied on technological innovations in order to scale our program. So we have, for example, developed a live monitoring system using Internet of Things to monitor our network of autosamplers. We have also innovated and designed autosamplers that could go deeper into the network, and also developed laboratory automation solutions, which could automate some of the liquid handling for wastewater processing. And of course, we also relied on our colleagues and collaborators to develop analytics platform to automate some of our analyses and to sense-make our data. So with that, I would also like to share some of the novel efforts that we have sort of invested in as Singapore. So as part of the PREPARE program in the Ministry of Health, which is a flagship research program, the environmental surveillance, transmission and mitigation pillar has also been identified as a key pillar in this flagship research program. And arising from that, there are also some projects which have been awarded to focus on the detection technologies for wastewater surveillance. This is a testament of the committed efforts that we have in terms of sustaining the wastewater surveillance efforts in Singapore and the wastewater surveillance R&D. So with that, I will move beyond our shores to some of the other efforts that we're doing with the region. So in partnership with the Asia Pathogen Genomics Initiative at Duke NUS, or one of our universities, and the Bill and Melinda Gates Foundation, we have established a regional network of wastewater surveillance practitioners so that we can do knowledge exchange and also understand what's happening in our region. So we do have partners as described in this map. And beyond that, we have also organized various regional exchanges on wastewater and environmental surveillance, including different types of training programs comprising laboratory testing, as well as field sampling and data and bioinformatic analyses. In fact, our next session will be held next week in partnership with the Asia Pathogen Genomics Initiative on 7th to 11th October. So with that, I would like to summarize with this slide, which is also something that we're really keen to be part of, because we know that as Singapore, we are a small city and country, and we really want to rely on the network and the global, our global collaborators and colleagues to really learn from you and to do knowledge exchange and technical exchanges so that we ourselves can sharpen our skill sets and our capabilities in wastewater surveillance. And with that, I would like to end the presentation and at the same time thank my colleagues in the Environmental Health Institute. And this is also only made possible with collaboration with the Ministry of Health, our water agency, which we tap on in terms of the sewerage network, as well as various academic partners and labs. And with that, I end my presentation and I thank you for your time.
Thank you so much, Judith, for that really informative presentation and for joining us all the way from Singapore at so late at night. Everybody in the audience, please put some questions in the Q&A, and I have some questions for Dr. Wong, and there's already one question. So I'm going to go ahead and work on moderating here. So there's a question about, I think it's for maybe some of the data that you showed for detection of other pathogens in wastewater. How are you making those measurements? Are you using quantitative PCR or digital PCR or sequencing?
Right, certainly. Thank you. And also thank you. It's really, I'm really glad to be here even despite the time. Really keen to be plugged into this network. And with regards to the question about the different protocols that we use, we primarily use a combination of qPCR and sequencing. For some of the panels, it could also be one of the multi-pathogen qPCRs or multiplex PCR assays. So it's a combination of different approaches. But of course, before we start on any of these, we do collaborate it with, for example, synthetic controls or maybe the virus if available.
Mm-hmm. Okay, thank you.
Thank you.
We have another question about sort of moving into the future. Do you plan to do continued monitoring for Zika and other pathogens broadly, or only when triggered by some other observation? So, how are you all thinking about adding and taking away targets from your wastewater surveillance program in Singapore?
I believe that this is a moving piece that will be collaborated as we, for example, understand the epidemiological situation in Singapore. If it is endemic, it might be necessary to monitor trending so that we can understand and collaborate, for example, some healthcare policies. And if it is an emerging threat, then perhaps it could be maybe more agile in the sense that we deploy it when there's a situation, and if the situation improves, then maybe we could step down some of the testing. But I think in essence, we do believe in a collaborated and agile response, that we shouldn't be testing something for the sake of testing it, but there should always be a public health use case at the back of our mind.
Mm-hmm. It was interesting to hear about the network that you've established across Asia. And I was wondering if you could talk a little bit more about sort of what the goals are of that network? I mean, knowledge exchange and lectures and everything sound really great, but is there a plan to sort of coordinate on monitoring, like you described the airport monitoring and mentioned that you thought monitoring at airports across like different international destinations could be really informative? Is that something that you think could actually be realistic and come about through that initiative? Are there other things that you guys are planning to coordinate across Asia?
Great, thank you. I would say that we are in very early days, and the partnership is also established together with the Asia Pathogen Genomics Initiative. Right now, our focus is really on knowledge exchange, capacity building, and capability building. So that's our focus currently. Of course, in terms of the ideal and the end state, if we could go together as a community, whether or not with our region or as really an international community, definitely aircraft wastewater sampling is something that we believe in, because we do already see, even with the initial data that we have, how powerful it can be. But I would say that currently at this juncture, at least for the region, we are focusing first on capacity building.
Okay, great. And then I have a question here about, you know, have there been any issues that, I guess just, you know, as you probably can guess, in the United States, sometimes sub-sewer shed sampling from manholes can be a little bit challenging with respect to public acceptance, or maybe some areas might feel more targeted in a negative way if they're getting their wastewater monitored from a particular building or a sewer shed. Have you had any issues? I know that it's very different in Singapore, and I was wondering if you could share if you've had any issues with sort of public acceptance or any sort of ethical issues that have come up locally with regard to sampling smaller populations through the manhole system that you're working on.
Right, thank you. Perhaps to also clarify, the block level sampling was really deployed only in the very early days where we really needed stringent control. And back then, people did appreciate that, you know, rather than going for a compulsory swab, you actually don't have to go for it, and it's just wastewater monitoring. If it's negative, then you know you actually don't have to do like swab testing. So the approach is very different. And of course, right now, when there's no need for that, we're actually not monitoring at such a high level of resolution, and it's monitored at groups of blocks levels where it is actually not possible to trace up. So in a way, it is really quite similar to monitoring a wastewater treatment plant. But it's just because the way Singapore is structured, we are very densely populated. That's why we rely on a network of manholes.
Okay, great. And there's a question from Lauren Stadler at Houston, and her system uses a lot of sampling from manholes too. So she has a question here about asking, can you talk about how frequently you monitor for different targets and how you establish your sampling and analysis frequency for different targets? In other words, do you sample weekly? And if you choose to sample weekly, how did you choose that, for example?
Right, certainly. So I would say that it is going back to the first question, really about like whether or not we continue to monitor, or whether or not we you know, do a agile approach. So in a way, the testing frequency is also calibrated that way, where if we are really looking in and really deep diving into signals, then we will test it more frequently. But if it's, for example, for SARS-CoV-2 trending right now at this juncture, then it may not be that frequent. But I'll be happy to take that question or discussion offline,
Okay.
if keen, yeah.
Okay. So we have another question here, which I think is related to the airplane wastewater. I think that we all have a perception that the airplane wastewater has a bunch of chemicals added to it in the aircraft as it's being carried. And I don't know if that's true or not, but can you comment on whether that is true? And if so, if those chemicals are disinfectants, if they have an impact on the pathogen detection abilities in the wastewater from aircrafts?
Right. There is definitely an effect. I'm not too sure So excuse me, I'm not too sure whether it is due to disinfectants, because when we do interview, for example, the ground handlers, they are uncertain about the disinfectant mix in the aircraft wastewater, but we are quite sure that there are inhibitors and it is also more concentrated. So in a way, the higher concentration may sort of help with regards to the fact that there's more inhibition. In some of the reports we have seen, they sort of approach it through like diluting the aircraft wastewater. And I would say that this is really one that we are also still evaluating ourselves. What is the optimal protocol for aircraft wastewater testing? It could be a combination of dilution as well as using different approaches to test the samples.
Okay, thank you. And then I think we have time for maybe one more question. So this one is sort of a technical laboratory question about laboratory automation. So are you guys using automation in your laboratory to do your sort of high throughput routine analyses? And if so, can you share anything about the automation and how useful or not useful it is in your laboratory?
Right. I believe that there are different like automated platforms right now. Whether or not it's for wastewater surveillance or for like just general liquid handling. For our automation in our laboratory, it was actually developed in-house. And that was because it was really at the peak of the pandemic where we were quite desperate to automate. I believe in retrospect, there is always areas of improvement. And I understand that there are some technologies right now which are off the shelf, which you could just deploy and do testing. And of course, with regards to PCR and sequencing, we are also aware of automated liquid handlers. In terms of the throughput increase, I would say that we can improve further. It's probably a percentage of increase so far. But definitely this is one area that we can do R&D in. And if there's anyone who has technologies to share or any collaborations to approach for us to trial, we'd be happy to discuss. Yeah, so I think for us, while we do see some improvements using the automated technologies, we believe that there's still a lot more that we can do in terms of improvement.
Thank you. And I'm sorry, there's time for one more question. And I know, Judith, this might feel like you're just getting bombarded here, but I'm really curious if you can say something about how you think sort of wastewater surveillance with the like Asia initiative might be different from like an initiative in Europe or North America, like in terms of pathogens that are most important to target. Do you think that there are unique pathogens in Asia? Do you think that there's unique wastewater systems? Like, what is it, what is unique about the groups that you collaborate with that you think we should know about, like why the world is different maybe? Because a lot of people on this call might be from North America or Europe, for example. What are some of those differences that we should be aware of?
I believe one difference could be the way that we sample wastewater. And again, Singapore could also be different from other countries in our region. There is likely a lot more unsewered communities that we need to look at in the region. And so we do need to develop capabilities in this area. And so, for example, even like using wastewater autosamplers may not be the mode for them. We may need to look at, for example, passive sampling methods and so on. So that's one in terms of sewered, unsewered communities. I believe the other one then, which is quite clear probably to most of us, is really the pathogens that we survey, because the pathogens that may be circulating in a predominantly maybe tropical area, country, could be quite different from a temperate country. So our region is largely tropical, so that could be something to think about as well.
Mm-hmm. Okay, thank you so much, Judith, for answering so many questions and for telling us about what's happening in Singapore. We really appreciate you coming to the webinar. Thank you.
Thank you for the invitation.
Okay, so Kyle is going to take over, and our next speaker is Elke Wollants.
Thanks, Ellie. And yeah, go ahead and share your screen and get started, Elke. Thank you.
Can you see me?
Yeah. Yes, we can see you, but not your screen yet.
Okay, just a minute.
Great. We can see your presentation.
Great. So, good afternoon, everybody. For me, it's afternoon. It's around 5:30 p.m. So since the COVID pandemic, we started to look for pathogens in the sewage. And now 4 years later, we learned a lot about wastewater. And today I will tell you more about measles. Sorry. So what is measles virus? Measles is a serious, highly contagious disease, and it's caused by an RNA virus of the family Paramyxoviridae. And it usually begins with a fever and cough and a runny nose, red, watery eyes, but this can be initially mistaken for a common cold or flu. However, these non-specific signs and symptoms are typically followed by clinical manifestations that are characteristic for measles. And this includes, as you see on the right, the Koplik spots. And these are tiny white spots in the cheeks. And subsequently, a measles rash appearing on the face before spreading downwards to other areas of the body. And in most cases, measles resolves on its own. However, severe complication can arise, especially in immune-compromised individuals. And according to the ECDC, 30% of the cases develop a complication, such as you can see here an ear infection, but can result into a hearing loss, diarrhea, pneumonia, which is a common cause of the deaths of measles in children, but also swelling in the brain, the eye disorders, what also can lead to blindness, and the fatal brain complication known as SSPE, which is fatal. So 1 out of 4 patients needs a hospitalization, and roughly 1 out of 1,000 people who gets measles dies. So young children are most at risk for the severe complication, but also adults can be affected. And measles is a vaccine-preventable disease, and after the introduction of the vaccine in the 60s, cases dropped with 97%. But the last decade, cases rising again. And why is that? Because of the growing anti-vax population, and especially after the COVID-19. According to the WHO, measles cases are rising globally, and in 2023 there were like 300 cases of measles worldwide, and this year it is even worse. Also in Europe. So this is a report of the ECDC that shows an increase of measles cases all over Europe, and you can see 2 problem countries where measles is epidemic. And these are Austria and Romania. Between January 23 and September 24, more than 23,000 confirmed measles cases were reported in Romania, including 21 deaths. And also a large measles outbreak in Austria. Since January 24, 500 cases reported, with more than 8 different measles virus strains, all connected to the B3 and the D8. So definitely multiple imports. And what about wastewater surveillance? Well, we are screening now different respiratory viruses for a couple of years now, and this is a paper where we compare wastewater results with clinical cases. But what about measles? Well, it can also be detected in wastewater. Measles is shedded by the urine and comes like that in the wastewater. But the we see only papers sporadically appearing on PubMed. I found those 2 papers from the detection of the measles, one from the Netherlands and one from Canada. So we received a report from the ECDC about the rise of the measles in Europe, and we decided to screen wastewater in Belgium in 3 different big cities, Leuven, Antwerp, and Brussels. So since the COVID pandemic, we screen wastewater on a community level by taking samples from a big wastewater treatment plant. And the sampling done here is with a time proportional automated sampler, which takes 50 milliliters every 10 minutes. And of this 24 hours influent, a half liter goes to our lab. And approximately half a liter of wastewater sample is used, and it is poured into a filtration device. And at the bottom of the machine, a filter was placed of 30 kilodalton, which retains all pathogens. Now the air pressure will push the water over the filter, and with this technique, we could concentrate 100 times, which is a lot. And what is important is a residue that you can see here. All pathogens are retained by this filter, and the filter goes into a tube together with 5 ml pure water. So after vortexing and spinning, the supernatants was used for extraction, and we use, for this case, the RNeasy kit of Qiagen for extraction. And for detection and quantification of the measles virus, we performed a qPCR with a primer and a probe set of a published paper from the Netherlands. And the CT values, they were measured with a fast virus 1-step master mix and a QuantStudio 7. And beginning of March this year, 5 samples were positive in the Brussels North area, with CTs varying from 35 to 39. And we also used a PMMV as a positive control. So this pepper mild bottle virus is a well-known plant virus and regularly used in the wastewater world. And we checked immediately with the health authorities because we had positive cases of measles. And at that time, there were 6 reported patients in that area. But because the wastewater is coming from a wastewater treatment plant that receives wastewater from 1,400,000 inhabitants, and this is indicated in blue, we assumed that there were more cases under the radar. And of course, in wastewater, you have to be sure this is not a vaccine strain, so that you detect by qPCR. So sequencing the sample was unavoidable. And the WHO guidelines, they recommend that the sequencing of the 450 nucleotides encoding the carboxy terminal 150 amino acids of the nucleoprotein should be used as the minimum amount of sequencing data required for determining the measles virus genotype. So we took the sample with the highest concentration and we amplified it by a nested PCR. And we sequenced this with the Sanger sequencing technique, and a phylogenetic tree was also constructed. And the sample was most closely related to a strain from Romania. And this indeed is the strain that causes the majority of the cases in Europe. And we reported this to the health authorities, and we put also an alert on Twitter. Of course, this was immediately picked up by our media, and our results were all over the news in Belgium. These are some articles from newspaper. Okay, it's all in Dutch, so I can translate some of them for you. Researchers from KU Leuven pulled the alarm bell after finding measles virus in Brussels sewage. Also, measles found in Brussels, this can indicate or more infections are under the radar. So actually, this was a good thing. Physicians now knew that they be extra alert for symptoms of measles, and also more vaccinations were given into the region of Brussels. And people at home, they looked at their own vaccination status and they went to the doctor to complete their vaccinations if it was not sufficient. And another wastewater treatment plant in the area of Leuven, Aquafin, it receives wastewater from 8 different municipalities. This comprised also 120,000 inhabitants. And in May 24, we found also a positive sample there. We sequenced it immediately, and the sample was also typed as genotype D8. Our health institute confirmed here only 1 case close to Leuven, but the chance that we would find a positive signal, 1 positive signal in 120,000 inhabitants, yeah, it's rather 0. So maybe also here, maybe more cases under the radar. Again, an alert on Twitter, and health authorities were informed. We also screened Antwerp, not the other big city, but samples at that time were all negative. And if we look at the positive cases in Flanders, this is the north part of Belgium, in August, then you can see that this year are many cases. So we have most cases in 12 years. And this is only the part of Belgium. If we look to the complete country, we see 462 cases this year. So this is an incidence of more than 40 per million. We have larger measles numbers than the Netherlands and even the USA, which has a population size 30 times more than Belgium. So we are really not doing well in controlling measles in Belgium. Oh, sorry, my last. So the most important thing to eliminate measles is vaccination. We need minimum 95%, preferable 98% vaccine coverage. Measles is a notifiable disease, so this means that it's mandatory to report measles cases to the health authorities, but not everyone goes to the doctor with measles symptoms. So we have groups in Belgium that refuse to get vaccinated and refuse to see a doctor, and that is problematic. So looking for measles in wastewater is actually a backup of your surveillance system, as we do for poliovirus. And in case of a positive sample, we can alert the health authorities, and additional vaccination can be administered. So with that, I would like to thank you and ask if there are questions from the audience. Thank you.
Great. Thank you so much, Elke. And just a reminder for everyone, if you do have questions, go ahead and put them in the Q&A box. So the first question I'll ask from one of the panelists is that, did you have any technical issues sequencing, given the very low concentration of measles in your samples?
Well, no, that went very well, but that was because of our NSF PCR. So it was a low concentration, so we need to do NSF PCR, or just regular PCR wouldn't work. You need to do NSF PCR, and then we just Sanger sequencing, and the sequence that I showed in my presentation was exactly the sequence that we had. So it was a nice, we saw nice graphs in the chromas file, if somebody uses that. So apparently it goes very well, yeah.
Great, thank you. So your use of PMMOV, did you use that for any sort of normalization, or was that really more just sort of a process positive control for your?
Well, normal in the COVIDs, we use it as normalization because we use graphs. There you can, and then we take like the ratio of the concentration of COVID and the PMMV. In this case, we didn't make a graph because we only had 5 positive samples. We just use it as a control. And as you could see, all the CT values were less or more the same. So the quality of the sample was also less or more the same.
Great. And just to clarify, you differentiated the wild type and vaccine strain from sequencing, not the qPCR assay. Is that correct?
Exactly. Yeah.
Yeah. Great. How often do you screen the wastewater samples for measles, and how often do you sequence the positive results? So basically, your sampling sort of approach. And I'll sort of add on, in addition to this person's question, what sort of % of samples do you see positive?
So not a lot of samples, because of course, after the warning of the ECDC, we started screening, and the only 5 positive samples that we ever got in the Brussels area, we showed you. But Brussels, we don't screen that regularly, because we live in Leuven, we don't have the budget, we are a research lab. So we don't have a lot of budget to screen the whole country. So the Leuven area, we screened for 4 years, every week. A lot of pathogens every week. Also measles. And in Leuven, there was only 1 positive sample until now. So that's very low. Brussels, yeah, it's the capital city. There were more positive samples, more inhabitants. But we don't screen it now anymore. But it should be screened regularly together with poliovirus. But it's not been done yet. Hopefully, there is a budget and a plan to do that.
Great. Was there a measured increase in vaccinations following the media attention, or do you have any information?
Yes,
or data?
I don't have exact numbers, but we heard that a lot of people went to the doctor for the vaccination. In fact, they stopped vaccination for adults for a while, because our vaccinations running out, because a lot of people were going to the doctor for this vaccination. I don't have numbers. In Belgium, it's extremely hard to receive vaccination numbers. But we heard there were a lot of more vaccinations given. So this is rather a good thing. Also, the thing in the media, that people are aware of it. People go faster to the doctor to get their vaccine.
Great. And then Ali asked another question too, and I had this down on my list. Can you talk about your negative controls, given the very low level of measles observed, to ensure that those aren't some sort of false positive?
Yeah, but the most of our samples were negative, so these were only the 5 positive that we had. So it's definitely not a contamination, because they were very rare, the samples that we get. And we also have, of course, in every run, we take negative controls with us, that we do for every virus. And we don't only screen for measles, we screen for a whole bunch of pathogens.
Great. Have you ever detected the vaccine strain? Again, if you
No, and that's extremely strange, actually, because in Leuven we know there are a lot of children being vaccinated, so it should be in the water. But maybe the vaccine strain isn't that much shed in the urine than when you have a normal infection. So it must have been that, because I never detected in wastewater, and we do it a lot now, for like more than since May. And we never, ever found the vaccine strain. Strange.
Yeah, perhaps an issue with shedding or how it's treated. And then the last question we have, and unless anyone adds any additional, which are definitely welcome, did you ever experience clogging for your samples when you put 500 milliliters through the 30 kilodalton membrane?
Well, yeah, it's with air pressure, so no, actually not, but it takes like 2-3 hours to run through. But I know this is an extremely sensitive method that we use, and it can only be done for a couple of samples. So if you have like 30 samples, you cannot use this technique, for sure. You have to use centrifugation, and then you have a lot less volume, so it's not that concentrated, of course. But no clogging, yeah, if it's really dirty water, we let it stand for like an hour, that most of the dirty particles are like beneath our bottle, and then we pour the supernatant more. But as you can see, the white filter is almost completely dirty when the water is completely goes through the filter. But it is the smallest filter that we have, because we want to do also screening for poliovirus. Poliovirus is an enterovirus, which is one of the smallest virus there is. So we have to use that one. Yeah.
Very interesting, all the different methods we've come up for concentrating. Well, I think we've reached the end of our questions. So I think we can thank Elke and Judith for very nice talks, and maybe give everyone a few extra minutes of their Friday back. So thank you, everyone. We'll see everyone next month for the seminar, and in a few weeks for the town hall. And have a nice Friday and weekend.
Thank you. Bye-bye.